And one more important thing in the infertility topic is the percentages. So they are asking even the percentages. So percentages are also important for you. So this is normal monthly conception rate. It is around 20% in a group of normal couples. So how much percent it is affecting? Infertility is affecting 15%. Out of total couples, 15% patients present with infertility. When do you call patient as infertile? What is the definition of infertility? Inability to conceive? Huh? Yes. Duration? This is very important. So, even in spite of regular sexual intercourse, so they should not use any pills, they should not use any condoms. So, no method to avoid pregnancy. In spite of regular intercourse, even for 1 year if they did not conceive, okay, then the patient couple is called as infertile couple. So, remember the duration. Duration is 1 year. Okay. Coming to infertility couple, they have asked the percentages. So, what is the cause? Female factors. What we think previous olden days, the female is the main cause for infertility. But now totally the concepts have changed. So, when we come to the percent, female, even though it is 40 to 50, even though high, but even male, they have asked percentage. It is 23 to 40%. So, the percent of both is important. In 40%, there are multiple causes, not a single cause. Okay. And unexplained, the incidence is 10%. So, remember all these percents, no more choice for it, because the persons have been asked the male cause, the factor, how much percent, female factor, male factor, and multiple causes and unexplained. Okay. The persons are very important. So, we know the inability to conceive after 1 year of unprotected sexual. So, what is difference between primary and secondary infertility? What is primary infertility? The patient has not yet conceived until now. That is primary. What is secondary? Patient had got previous history of abortions, stillbirths, okay, or any IUDs. Patient is not having live child, but the patient has history of conception in the previous. That is called as secondary infertility. Okay, she has conceived, but she is not able to get a good child. That is secondary infertility. So that is infertility after previous. Or suppose the patient comes to us, my child is around 12 years or 8 years. Now I want one more child. I am not conceiving. So please give me treatment. That is secondary infertility. It's not only the abortion or whatever. The patient has got one child. After that, there is a gap of some years. There is no fixed gap for the secondary infertility. The patient has not yet conceived. That is called as secondary infertility. So, what is sterility and infertility? Infertility is if you give treatment, the patient can conceive. But whereas in a case of sterility, it is the absolute. The patient cannot conceive. Absolute inability to conceive. It is sterility. So, and this was asked for you. What is fecundity? What is fecundability? What is fecundity? So, it is ability to achieve a live birth. Live birth. So, if the patient should get a live birth, it is fecundity. What is fecundability? Ability to conceive in one menstrual cycle. Either it can be abortion or a stillbirth, whatever may be. So, if it is a live birth, we call it as fecundity. If it is a ability of the patient to conceive, we call it as fecundability. Is it clear? Fecundity and fecundability? Any doubts? Fecundity and fecundability, they are not infertility. These are questions asked related to infertility. So, what is fecundity? It is normal conception rate. We have discussed initially 20% conception rate. So, what is fecundity? It is the ability of the person, normal couple, to conceive a live birth. That is called as normally in one menstrual cycle we call it as fecundity. So, how much percent of the patients are able to conceive in one menstrual cycle? Okay, either they can be live birth, abortion, stillbirth, whatever it may be. So, that is called as fecundability. These are not infertility. This is the patient is able to conceive. Okay, either if patient is able to conceive one good baby, live baby, it is called as fecundity. If the patient is able to conceive but still not able to get a live birth baby, that is called as fecundability. Okay, these are the two terms nowadays they are asking. Coming to the infertile couple. So, how do you evaluate? Always an infertility couple, if they approach to us, the first thing we have to do is get both male and female. Normally, the male will not come to the hospital. I have seen lot of patients, especially in towns, the male will escape. The cause to factor will be male, but the male will escape. The female will be coming as if she is the culprit. So she'll come and ask, doctor, I'm having infertility, please examine. The next thing what you need to do is go get your husband, then only I'll do investigations. So treating the both male factor and the female factor at the same time is very important. So these are all the persons which has been asked for you. Multifactorial, multiple causes we have just discussed. It is 40%. So other than that, within the female factors, we divide it into either it can be ovarian factor starting from the lateral end, or it can be tubal factor, or it can be uterine factor, or cervical factor, or any peritoneal cause. So this is how we divide it. Okay. Or either it can be sperm defects, any male defects. We will go in detail what are all the various defects. So normal conception, what is going to happen? The egg is going to get released, the sperm is going to come here, it is going to get fertilized. Site of fertilization is fallopian tuba, ampulla. So ampulla, so once it comes here, it goes and gets implanted. Which stage it is going to get implanted? Blastocyst. Fourth cell stage is which is fourth. Blastocyst is a fourth cell stage or not? It is not a fourth cell stage. Then what is before, early stage before blastocyst? We call it as morula. So infertility, the basic test, these are the basic tests. So any male factor go for first semen analysis, and female factor, I told you already, the basic test which you need to do in a board. How do you know either the patient is ovulating or not? Previous classes we have discussed without seeing the board. Yeah, which hormone you want to do? FSH on which day? Day 3 FSH, yes. It indicates how many ovarian reserve. But how do you know whether the patient is ovulating or not? Whether the patient has released egg or not this cycle, how do you know? Yes, exactly correct. Serial ultrasound study. Other tests than that, I already told you the patient is not willing for serial ultrasound. What test to do? Progesterone, correct. Serum progesterone, which day? Maximum progesterone, which phase? Maximum progesterone is seen on 23rd day. Okay. That's what, remember the menstrual cycle. Entire the infertility is based on the menstrual cycle. That's why I am finishing this topic. So we can know whether the patient is ovulating or not based on serum progesterone, ultrasound study. What you are going to see in the ultrasound? How do you know whether the patient is ovulating or not in ultrasound? Size of the Graafian follicle. What is size of the dominant follicle? Fast. Huh? 18 to 20. 18 to 20 mm. So that is how we decide. Okay. Other than that, what can we know? How can we know the patient is ovulating? So they have asked which of the following are all the tests of ovulation. So one more is the endometrial biopsy. How do you know whether the patient is ovulating or not? By doing just an endometrial biopsy, you are going to take the endometrium and you are going to see. So what changes are seen? On which day you are going to do endometrial biopsy? Normally always do an endometrial biopsy just before the periods. Why just before the periods? This was asked for you. Because on the day of, if you take a specimen of the endometrium on the day of the biopsy, if it shows proliferative phase, what does it indicate? Ovulatory or anovulatory? You have taken biopsy. So this is the 14th day. You have taken biopsy just before periods. This is menses. You have taken something around 26th day. So if it shows proliferative phase, what does it indicate? Ovulatory or anovulatory? So anovulatory. If it shows secretory, what is? Ovulatory. Is it clear? So always a ovulatory, the endometrium should be secretory. If it is proliferative, means it is anovulatory cycle. So it is one of the things which was asked for you. So if the proliferative phase, it shows it is anovulatory. If it is secretory, it is ovulatory. What is the typical endometrial feature during the process of ovulation? On the day of ovulation, if you take, what will be the scene? No. On the day of ovulation, where do you see furning, Lakh? Where do you see furning in endometrial biopsy? Where do we see furning? Cervical mucus. So furning is not about uterus. I am speaking about uterus. So what on the day of ovulation, the typical feature I told you to remember. What do you see? Forgot menstrual cycle. I'll give you a chocolate if anyone answers. Silk. Boys, okay, I'll give you pen. Girls, chocolate. Online, can anyone of you answer? On the day of ovulation, if we take a biopsy, so what is the typical feature we see? Histopathological finding. No, one typical feature which was asked frequently. Shripati, once again think. No, other than that, we are not vacuolization, Nandu. Yes, exactly. Nandu, it is correct. It is subnuclear vacuolation. So, you will be getting chocolate. Next time, I will never tell that I will get chocolate. So, it is subnuclear vacuolation. It is very important thing what you will see it on the day of ovulation. Early, what you see? Did you answer without seeing or with seeing the notes? Good, very good. So, proliferative phase we see mitosis. So, these are all the typical features. Even Nandu has answered correctly. Yeah, MD, everyone, online people, they are answering correctly. Okay, yeah, coming to, this is the important features in the endometrial biopsy. Okay, next. Coming to, once we have finished the ovary, so now we know either the ovum is ovulating or not. So, what are all the other tests of ovulation? Other than this, whatever we have discussed. How do we know whether it is ovulating or not? Basic tests of ovulation in your gynec SHA. Basic test. I don't want to do any investigations. Patient can sit at home, nicely relax and can know. Basal body temperature, very important. So, how much degree of rise? That was asked for you. Everyone can answer basal body. How much degree of rise? 0.5 to 1. Okay, it is 0.5 to 1. During period of, it is not like coming to ovulatory and anovulatory cycles. If we take the anovulatory cycles, they will be like this. Whereas ovulatory cycles, after ovulation a peak, before ovulation also a bit, but during after ovulation a bit peak like this. Whereas anovulatory there is no peak. Okay, so a degree rise of temperature 0.5 to 1 degree. That is basal body temperature. Other tests of ovulation. Other tests of ovulation. Okay, anyway, that is a separate topic. I will deal with later. So we have finished the ovulation factor. So now I want to check the tubal factor. By which test can I check? Okay, exactly correct. One is hysterosalpingography. Next, what is the dye you use for hysterosalpingography, which was asked for you? Dye. Name of the dye. Diiodine, otherwise called as urographene, which was asked. Okay, diiodine, otherwise called as urographene. This is the dye which is used for hysterosalpingography. Dye enti? Ba nidripoyara? Jol bartnana? Okay, yeah. Other than hysterosalpingogram, what else you want to do? I don't want to do HSG because it is very painful, or sometimes the patient is. And one more important for you, there are two dyes in this. One is oil soluble dye and water soluble dye. So the complications with oil soluble dye is high when compared with water soluble. But the picture whenever you take, it is very clear with oil soluble dye. So this was asked for you. So there are two dyes. One is oil soluble and water. So oil soluble dye if we use, we will get a very good picture of the tubes and all. But it has got a complications like granulomas, oil granulomas and all. Water soluble dye doesn't have any complications. Okay. Okay. Other than HSG, what other tests you want to do? HSG is not in your bits. So which test you want to go to for tubal patency? Exactly. The other tests are hysteroscopy. Along with the hysteroscopy, phalloscopy. It is called visualizing the tube via hysteroscopy. What is hysteroscopy? You know, all of you know what is hysteroscope? Hysteroscope is nothing but visualization of the uterine cavity. Okay, from the vagina we introduce some instrument like a laparoscope. So now hystero means uterus. We are visualizing the entire uterine cavity. It is called as hysteroscope. So once you enter the uterine cavity, then you want to visualize even the tubes. So you can go for the tube special instrument called as phalloscopy. Other than that phalloscopy, nowadays it was asked. One more scopy. Chromoperturbation. What is chromoperturbation? Where you are going to do? Exactly correct. So the best test, this was asked for you, the best test to diagnose a tubal infertility. So there are HSG, hysteroscopy, phalloscopy, chromoperturbation, everything. Out of all this salpingoscopy, the best test is laparoscopic chromoperturbation. So if you want to confirm the tubal factor, laparoscopically what we do will be from the laparoscopy, from the above we will be visualizing directly into the cavity, peritoneal cavity, directly we will be visualizing the tube, enter the ovary, uterus. What will do from down, I am going to inject some dye into the cervix. So if the tubes are patent, automatically the dye gets filled. Okay, the tubes are open, what is going to see? At the femoral end I can see dye coming out, because whatever the dye I have pushed out, the tubes I can see. So from above I put a laparoscope port and directly I am visualizing whether the tube spillage is there or not. That is called as laparoscopic chromoperturbation. So the best method, it is not the first method, always remember it is best method but not the first method. Yeah, these are all the various methods. Coming to, now I finished the tube, now I want to detect uterine factor. So how do I detect uterine factor? What all the various tests without seeing the board? Yeah, Kausar, it is exactly correct, chromoperturbation. Yeah, next. Hysteroscopy. Yeah, one is hysteroscopy. In visualizing directly we can see the uterine cavity. Next, other than uterine cavity, other than ultrasound, the first basic test. So to detect the uterine cavity abnormalities and all, the basic test is ultrasound. What I do is an ultrasound. So this is how I detect. So this is, what is this picture? HSG. So once this is the dye whatever they have injected, this is the uterus, nicely you can see. And this is bilateral spillage. Are you able to see some white thing here? This thing, see here nicely it is seen. Okay. It indicates there is bilateral spillage, means the tube is patent. That's why the fluid, whatever the dye you are injecting, it is seen on the either ends. Are you able to see dye this side? This is the picture, dye. Yes, this is the uterus. Are you able to see this side any dye? Is it clear how a block tube will be? This how. Are you able to see some round shadows? Filling defects. These are called as filling defects. So normally previous thing, are there any filling defects? Nothing. Normally the shape of the uterus. Whereas here you are able to see some filling defects. They can be either polyps or they can be any fibroids. Okay. It is seen in the cavity. Okay. Next, this is sonohysterogram. What is sonohysterogram? Sonohysterogram. Or what is sonosalpingography? Or sonohysterogram? Sonohysterogram, saline. Yes, what is that saline sonohysterogram? Nothing but we inject directly fluid. Where do we use Foley's catheter? To drain the bladder. Now I am taking the Foley's catheter and putting it directly into the cervix. Now I will fill the uterus. Okay, with the fluid. Whatever the black color is the fluid. So now I have injected some fluid into this. So this is all the endometrial thickness. Now I can see some abnormality within the endometrial thickness. Either it can be fibroid or polyp. So that is saline sonohysterogram. I am injecting saline directly into the uterus and visualizing through ultrasound. Okay. This is the entire uterus. At the center I have filled some fluid, black color, where I can see some mass. So coming to male factor, very important topic. Male factor infertility, semen analysis. They have asked many times, many questions in this topic. So without saying, anyone tell me, what are all the semen, when do you want to do? So a male person has come. So when do you advise the male, the husband to give his sample? Exactly correct. Minimum 2 to 3 days. Minimum 2 to 3 days of abstinence. The very important thing. Why? Without abstinence, what it is going to happen? Suppose the patient yesterday he had a coitus. Today he came. If I advise him to go and give the sample, what's the result? What's the variation? The count will be less. Okay. The volume will be less. The amount of sample will be less. So always minimum 2 to 3 days. That is the minimum period. Exactly good. Very good point. Next. So once you give this minimum 2 to 3 days of abstinence, the first thing what you need to tell to the patient. Okay. And when do we call it as a abnormal semen analysis? So we got the report. Based on one report can we call it? So how many reports should you need to call it as abnormal? How many reports you need? Minimum 3 reports. Remember, it was given for you. Minimum 3 reports should be abnormal to call a male factor infertility. So today the patient has gave the sample after 3 days of abstinence. It came as abnormal. So when do you want to repeat? After 3 days, 3 days, 3 days? 3 samples. So it is 2 weeks and 2 months apart. Today the patient is given a sample. Repeat the sample after 2 weeks. Once again to confirm it, even after 2 weeks, after 3 days of abstinence, the report is abnormal. Repeat the sample after 2 months. So now you got consecutive 3. So if the 3 reports are abnormal, then it is abnormal semen analysis. So never call it an abnormal semen analysis based on a single report. Minimum how many samples? Yellow shirt. Minimum how many samples? 3. How many weeks of duration? 0, 2 weeks, 2 months. Exactly correct. Okay. Why 2 weeks, 2 months? Why we are taking that much time? Why can't I should take a regular time? Why I told you 2 weeks, 2 months? Why this 2 weeks, 2 months? Why you need to mug up as 2 weeks, 2 months? Why not 3 days? Why not 5 days? The analysis, whatever the sperm production it is detecting, that occurred 3 months ago. So if you repeat immediately, definitely the sample will be abnormal. Okay, that is the normal sperm duration to be formed. Is it clear? So these are recent WHO 2012 guidelines. In Gynecia and all, those are old guidelines, 2009, 2010. These are recent WHO 2012. So the guidelines have changed. Whatever your PG books and all, they show 2009 guidelines, but these are 2012 recent guidelines. They have changed WHO. So previously, what is the normal volume? So first, what we'll check the normal volume. The normal volume should be always greater than 2 ml. Count. Previously, it was 20 million count, but now they have come down to 15 million count. So if it is greater than 15 million count, call it as normal. Morphology. So greater than 40%. Morphology, previously it was 50 to 60%. Now they have come down to 40%. So morphology greater than 40% should be normal. Motility, normally 30%. Previously it was 50, now it is 30. So the guidelines have changed. These are very, very important. This topic very frequently asked. So always remember, the semen analysis report has changed totally. WHO 2012 guidelines, these are. Volume should be, what is the normal volume? Finished writing, everyone? Write fast, write it fast. So the leukocyte count should be less than 1 million. Finished? Yeah, Hamza, you are correct. Once you finish, tell me fast. So they won't give you like this, which of the following is normal, which of the following is abnormal. So the PG bit for you will be, so this percent and this percent. Suppose a count with 15 million. So what is 14 million they will give you, or 16 million they will give you. They will give you 18 million. So what is your interpretation? Agiospermia, normospermia. If it is 18 million, what is your interpretation? Without seeing. If the motility is 40%, what is the motility? So greater than 30. Previously it was 50%, but nowadays they have changed. So the picture, what the question they are asking you nowadays is, they won't give you what is normal, what is abnormal. They'll give you the picture and they'll ask you, either comes under normal or abnormal, or what is your next line of management. Either you call it as normal or you want to go for other procedures to treat agiospermia. Okay. So these are typical WHO 2012 guidelines. Yeah. This is the basic spermatogenesis. Can any one of you explain oogenesis? In the previous class we have discussed in menstrual cycle. Any one of you? Oogenesis, how it divides? Oogonia are from origin. Yolk sac, exactly correct. So they come from yolk sac. They divide it into. So here you can see clearly. These are the oogonia. They come from yolk sac. They divide it into primary oocyte. Next they divide it into secondary oocyte. These secondary oocyte further these are called egg. Okay, polar bodies. Meiosis 1, meiosis 2. Where do we see meiosis 1 at which phase? Meiosis 2. So until that time they are in which phase? Suppose at birth, at which phase they are? Prophase? Complete. I told you something front, something behind, add it. Dicotyl stage of prophase of the first meiotic division. Okay. So the same, the spermatogenesis also the same. So whatever the spermatogonia, they divide into primary oocyte. So they further divide to form secondary spermatocytes. These are secondary spermatocytes. They divide to form spermatids. Okay, this is the cycle. This is called as spermatogenesis. Very important. This is called as spermatogenesis. Remember this term, why I told you spermatogenesis. What is spermiogenesis? See here. What is spermiogenesis? Spermiogenesis. So whatever the sperms they are formed, they undergo some process, okay, where within the epididymis. So where are these spermatogonia? Where are they? They are in testis. So while coming next from testis, where do they go? What is that connection? Anatomy. From testis ekkada em potundi paiki? Vas difference. Epididymis next vas difference. So vas difference and all, they undergo some changes. That is called as spermiogenesis. And one more important change in the sperm is capacitation. What is capacitation? Where does it undergo? Exactly, this was asked for you. So the sperm undergoes some changes. Once the sperm enters the female uterine cavity, it undergoes some changes where? In the cervical mucus, not in the uterus, not in the vagina, not in the vas or not in the testis. It is called as capacitation. Why capacitation is important? The capacitation is the main thing which is making the sperm to enter the egg. Okay, it releases some enzymes so that it will prevent further entry of the next sperm. So it undergoes some changes for this and all. This is called as capacitation. Where is the site of capacitation? Exactly, correct, good. Okay, so what is normozoospermia? So normal ejaculate, if the normal volume, normal everything, it is called normozoospermia. Normal, what is the normal wall count? So when do we call it as asthenozoospermia? What is astheno? Motility. Astheno, if there is defective motility, we call it as astheno. Don't remember these terms. Just remember, no need to remember the percentages. The percentages in the previous slide are very important. Just note the terms. If there is defect in motility, it is astheno. Then what teratome means? Teratome means, always remember teratogenic. So teratogenic means morphology. Okay, remember like that. Don't get confused between astheno and terato. Terato is always the morphology what you see defective. So if there is defective morphology in the sperms, we call it as teratozoospermia. What is difference between azoospermia and aspermia? Without seeing the slide. Azoospermia is decrease in the with no azoospermia is no spermatozoa. If there is no semen itself, it is aspermia. Okay, is it clear? So azoospermia is whatever the ejaculate is there. What do you mean by semen? Is it only the sperms? No, there are a lot of things. The fructose, there are many things which are released even from the prostatic secretions and all. So if secretions and all there, but the sperm is not there, we call it as azoospermia. Whereas in a case of aspermia, there is no even prostatic secretions also. Okay, the total, the semen and all is abnormal. There is no semen itself. That we call it as aspermia. Is it clear? The terms they have been asked for you in the previous slides. Yeah, Bibu, it is correct answer. So, are you able to see from there the colors, the pictures? So, this is the normal sperm here you can see. This picture is very clear, or else we will take this. So, this is the normal sperm. So, what is this? Head, sperm head. What is this? This is tail. This is tail. In between something. Here you can see it's a medium color there. Is it clear there? I will show you with this. This part. Where will be the acrosome? Above. So here you can see this is the acrosomal cap. This is the head. This is in between the neck piece we call. This is the tail. Okay. So what are all the abnormal? They have asked which of the following are abnormal. So when to call it as an abnormal sperms? So when you examine, are you able to see the tapered sperm? So the previous was, there was no tapering. It is something like a globular. But here you can see tapering. So either tapering or two-headed. That this is the two-headed sperm. Here we see the tapering. So these are all abnormal morphologies. Round cells. How much they should be count? Less than leukocytes? They have seen. So these leukocytes and all they have seen abnormal round cells. So these are all the vacuoles. Within the sperm you can see some abnormal vacuoles. Or large mid pieces. This is the mid piece which is very large. Tail there. There is no tail in this. So how do you divide the cause? The causes can be pre-testicular, testicular, post-testicular. So the pre-testicular means where the defect is. Pre-testicular means even before the testis. So where is the defect? At which level? Testicular is testis defect. Post-testicular is the sperms are released but the patient is not able to ejaculate. From testis to the ejaculation there is problem. There is difficulty in the vas difference or difficulty in the penis or something wrong. The patient is not able to ejaculate. That is post-testicular. Testicular is within the testis there is defect. Then what is this pre-testicular? Something which is controlling the testis. What is that? Higher levels. Hypothalamus and pituitary. So the defect at the higher level. It is called as pre-testicular defect. So we will discuss it in the later. Now we are coming to the testicular defect. There is defective spermatogenesis, means the testis is not able to produce sperms. So what are all the causes of the defective spermatogenesis? There can be undescended testis. The most common cause is varicocele. We see in most of the patients. So patients will be totally asymptomatic. But when we do a scrotal Doppler, the patient presents with varicocele, very common cause for this infertility. And hydrocele. So anything which interferes with the sperm production. And nowadays we are seeing mumps, the male patient will be having mumps, orchitis. So from mumps the patient will be having orchitis. Next later there will be defective spermatogenesis, okay, or any thyroid. So even serum TSH in infertility, not only the male patient also we need to go for thyroid profile. So any thyroid abnormalities and defective at any pituitary level, okay. Klinefelter syndrome. What is the Klinefelter syndrome? 47XXY. Okay, there will be defective spermatogenesis. Remember, what is the typical presentation of testicular feminization syndrome? How, by looking, how can you say it is testicular feminization syndrome? So a female, no pubic hair, a bit still refined answer. So whatever boys see, what a girl, very beautiful girl without any hair, tall, fair, these are all features of testicular feminization syndrome. So tall girl, beautiful girl without any hair, so boy gets automatically married to that girl. So but after marriage they come to know she is not become fertile. Testicular feminization, typical features asked in your question. So long without any hair, testicular feminization syndrome. Okay. Okay, where are the Klinefelters? 47XXY. Obstruction of the efferent duct. This comes under which cause? Pre-testicular, testicular, or post-testicular? Post-testicular. So the typical feature is obstruction of vas deferens or anything obstruction, means how the semen analysis report will be. Either they can be agiospermia or aspermia. It's not always the aspermia. Either they can be even agiospermia. So in obstruction, so either it can be due to the tubercular cause or gonococcal, cystic fibrosis and all. So which motility disorder will affect? The ciliary motility, the name of the disorder. Exactly. So it is cartilaginous syndrome. So even these are all cystic fibrosis and all, even they affect the motility. Okay. And Young syndrome. Remember, they have asked these syndromes. Which of the following is a cause of infertility? Low pitch voice there. Bibu, let me know whether the voice is normal or not. So the patient has got, everything has got sperm, but the patient is not, the testis is normal, the pre-testis is normal. So once you examine the sample, it is normal, but the patient is not able to deposit within the female. Why? Either it can be premature ejaculation. So even before they go inside the female vaginal tract, they are ejaculating. That is premature ejaculation. or hypospadias, or patient either he should be impotent. So these are all the causes for male infertility. And very important, 5 important points regarding the postcoital test. So what is the importance of this postcoital? What is the other name of this test? Can anyone of you answer? Huh? Sims test. Other name? Pakkane rasan kada, Sims pakkana. Hannes test. So the other name is Sims test or Hannes test. What is Kleher-Betke test? What is app test? Where do we do app test? Vasa previa. So what is the importance of this Sims test and Hannes test? This is called as postcoital test. So when do you do this test? After how many hours of intercourse? UG answers are gone now. All PG is perfect. How many hours? How much percent? So these are all your PG answers. So when do we do? It should be done on 12th and 13th day. Why only on 12th to 13th day? Why not on first day of the period or on 26th day of the period? Ovulation. Why ovulation is related to this test? Can anyone of you answer? So if you know what we are seeing in this test, then you can answer. So what we are seeing in this test? The main thing, we are looking not only into the male factor infertility, at the same time we are also looking into the female factor, that is the cervical mucus. So if during ovulation there is the type of the mucus is different when we compare with the later phase. So can any one of you tell me how the proliferative phase, the mucus, the estrogen dominant mucus, how the cervical mucus, typical features? Terms ala padala, PG answers ravala. The terms, what do you call the pattern as? Last, yellow shirt, indaka cheppar kada answer. Estrogenic phase, how the cervical mucus will be? Ferning pattern, the typical ferning pattern. Other name? Simpy bargaining, spin bargaining, spin bargaining or ferning. Okay, the pattern which you see in the cervical mucus only under the influence of estrogen. So where do we see estrogen dominant? First phase or second phase? First phase. So what is the cause of LH surge? Increased or decreased? Increased levels of estradiol. Estradiol. What is the hormone? Estrogen we see in postmenopause? Estrone. Why estrone? Ela gurtu pettukunnaru? O-N-E-E-N-O. Amma. Kodlu kuda gurtu pettukunnaru. Good. Where are we? So what are all the typical features we see in secretory phase? Suppose I have taken a cervical mucus of the secretory phase. So what is the typical feature of the secretory phase? Name. Okay, name. Spin bargate and ferning are typical for estrogenic. For progesterone, which is typical? Exactly. Yeah, very good. It is stack phenomenon. What is stack phenomenon? Ila lavute ila cut ayipotundi. Whereas estrogenic, ila lavute ila saagutadi rubber laga. That is estrogenic. Whereas stack is, if you try to pull, it will cut. Okay, that is stack phenomenon. Okay. So these are asked, all previous asked, whatever I am telling you, not even one point is rubbish or not even related to UG. All are PG related bits. Okay. So what are all important findings? That's why we do it on 12th to 13th day is, it indicates the mucus under the estrogenic phase. Why mucus under the estrogenic phase is, only the mucus under estrogenic phase can allow the sperm to enter into the female tract. Once in a progesterone phase, the cervical mucus will not allow the sperm to enter into the uterus. Okay, that is why this mucus is very important. And ovulation, that's why we say to have an intercourse immediately during the period of ovulation. Why? Because the cervical mucus is very important during that period. Even they have an intercourse on 26th day, still they cannot have a child because the corpus luteum already ruptured. The egg is released. What is the normal lifespan of egg? Sperm? Which has got long lifespan? Okay, finished. Yeah, Shali, it is correct. It is stack phenomena. Yeah, so done within 8 to 12 hours of coitus. So if you want to do this test, do on say 12th to 13th day. You know now why to do it on that day. Next, it should be done within 8 to 12 hours of coitus. Next, so what are all the features you need to check in this test? What we are taking, what we are testing in this? So ask the couple to have an intercourse, ask them to come after 8 to 12 hours. take a sample from the cervical mucus, okay, of the female patient and check it on a smear. So what you are going to see on the smear, the minimum sperm count should be 10 to 15. The two what sperms, they should be motile. What motility? Forward motility or rotatory motility? Forward motility is always normal. Rotatory normal or abnormal? Rotatory or shaky is abnormal. So forward motility minimum 10 to 15. At the same time, the cervical mucus, what you are going to assess? Estrogen control. What is there? Phenomena. Pointing, otherwise called as spin bucket. Okay, these are the two. These are the features what you are going to do in the post-coital test. And one important, the contraindication for this test is in an infection. Why? Because in an infection, the cervical mucus will not allow the sperm to enter. Okay, even though if you do the test, there will be abnormal results. So in a patient, female patient with infection, don't allow the patient to undergo this test. Okay. Sperm 48 Sripati, it is wrong. It is the egg. Oh, you answer this. When you want a break, tell me. I am not going to give a break, okay? Because I started late. If you want a break, tell me. Huh? Feed up pipe in the brain. Ivala kotta points to. The infertility is a very high yield topic for you. AIMS, All India PG, Andhra PG, whatever the test you go, there will be question from infertility. Basics of reproduction. Yeah, why you are taking this much time? What is it is showing? The postcoital test shows non-motile sperms in the smear, whereas there are motile sperms in the posterior fornix. So what is the defect? Hypospadias ante enti? As a sperm there is defect in deposition. So the patient will not deposit either in posterior fornix or in cervix. So C is not the answer. They are telling some sperms either motile or non-motile, they are going to see. Can we call it agiospermia? No. So C and D. Now answer A and B. Either it is whatever the coital practice, whatever faulty, right or wrong, if it is inside the cervix or posterior fornix, so no need, the male partner cannot deposit directly into the cervix because the os is closed. Normally the deposition will be in the posterior fornix. The sperms will go. Okay, that's why we call it as forward motility. They will go through the cervical os, then upward. So never the os is open and kept open for the sperm to enter. It is always closed. So it is not a faulty coital practice because we are able to see in the posterior fornix, that is quite normal practice. Immunological defect. The answer is immunological defect. That's why we do one test to detect this. What is the test? So any defective immunology in the sperm. What is the test? Which test? I know that there are motile sperms in the fornix but not in the cervical smear. I know it is immunological test. I want to detect it. By which test? Yes, exactly. Very good. Anti-sperm antibodies. There are antibodies. So which are preventing the motility of the sperm, which are preventing the sperm to enter. So how can I detect it? They are in the cervical mucus. So go for anti-sperm antibody test. Is it clear? Not immunofluorescence. It is antibody. Anti-sperm antibody. Yes, next. ABCD fast. So B, it is estrogen. You know estrogen or progesterone form pattern? Estrogen. So always it is because of the production of the sodium chloride due to estrogen. Yeah. Coming to next slide. So what are all the various abnormal semen tests which we can detect the abnormal sperm other than semen analysis? So there are within semen analysis we know there are various causes. How to detect these causes? So various tests which have been asked for you. So one is sperm penetration test, and remember these are all abnormal semen analysis to detect abnormal sperms. Just remember the names. Human Jonah binding assay. Nothing but they'll put an egg. Okay. Jonah egg, and they'll give a sperm so that they'll see how much the sperm is able to penetrate. So these are nothing but the penetration test. They'll detect the abnormal penetration. And Miller-Kuchstroke test. It is also penetration. So if the sperm is not able to penetrate less than 3 centimeters at 30 minutes is abnormal. Normally the motility, the motility of sperm is very high. So if it is not able to penetrate less than, if it is only penetrating less than 3 centimeters, it is abnormal. That is called as Miller-Kucherov test. Okay. And nowadays we are using electro-optical methods and hypoosmotic swelling test. So if any abnormal sperm is there, the tail and all, the body will be swollen, the tail will be swollen. So these are hypoosmotic swelling test. And how to detect abnormal semen? One thing is testicular biopsy. So to detect a testicular cause, directly we take a biopsy from the testis, that is testicular biopsy. Now just now we have discussed clean filters and all. How to go? Chromosomal study. So which of the following is not a test for male infertility, they will ask you. Okay, these are all the tests for male infertility. Not size of the ovum, the 3 centimeters is the distance the sperm should penetrate. So within 30 minutes time they will give you. So if the sperm is not able to move within 3 centimeters, so if it is moving only 1 centimeter or 1.5 centimeters, that is abnormal. So they will see how much it is penetrating. Okay. It's nothing but what they do is, they will just take a cervical mucus, they will take on one slide and they will put, previously what we are taking, cervical mucus with the sperms. Now we take it separate, that's it. Previously we used to take a combination, now we take a cervical mucus on one slide and we will put one sperm and we will see how much it is penetrating. So if it is not going less than 3 centimeters into the cervical mucus, that is abnormal, okay, at 30 minutes. That is nothing but Miller-Kucherov test. If you do it separately, it is Miller-Kucherov. If you do it combined, it is postcoital or Sims or Hanard's test. Very thing. So this is what they give you. Now tell me. So pre-testicular means where the defect is? Where the defect is? Pituitary. So what is going to happen at FSH and LH? Low FSH and low LH. So whenever there is low FSH and LH, automatically it is going to influence testosterone because it is going to stimulate the testosterone. So low testosterone. So the picture they will give you. So they won't ask you directly which of the following is the cause of pre-testicular cause. So they will give you the patient undergone some analysis for infertility. There was low testosterone, low FSH, central defect is there, low testosterone. Okay, it indicates it is pre-testicular cause. Without slaying the slide, now answer me. Suppose if it is testicular, how the picture will be? Testicular, if the cause is testicular, what is going to happen to testosterone? Decreases. So once the testosterone decreases, what is going to happen to FSH? Decreased testosterone, FSH? Decreased estrogen, FSH? Increases. Always the feedback mechanism, either the female or male the same. Okay. So if the picture is low testosterone and high FSH, the cause is? Yes, very good. Now tell me post-testicular. How the post-testicular? What is going to happen to testosterone? And FSH? Then how the picture will be? So normal FSH, normal testosterone with azoospermia. The cause is it clear for everyone? So the questions have been asked for you like this. Okay, very tricky questions but very simple. And if there are sperms in urine, what do you call it as? So if you ask the patient to give a urine sample, normally there are sperms in urine, normally it should not be there. If there are sperms in urine, it is called as retrograde ejaculation. Instead of forward, retrograde ejaculation. So that's why in urine sample we see sperms. So it indicates retrograde ejaculation. Yeah, answer this. By? Good, exactly correct. The answer is D. Coming to treatment. So what are all the various treatments we give? So first the baseline treatment is to correct any abnormal factors. So ask the patient to stop smoking. Okay, any heat. So if the patient is working near heat furnaces and all, so ask the patient to avoid such a heat conditions, high heat conditions. Next, and some patients most of the time they go for lubricants during intercourse. So they have a spermicidal activity. Some lubricants have spermicidal. So ask the patient to stop that. Other than that, hormones what we are giving is clomiphene citrate, very important hormone nowadays for male infertility. Where do we use this clomiphene? PCOD patients, suppose a young female has come unmarried, you want to give clomiphene? Where do we give clomiphene? Ovulation induction drug, the very most common indication for clomiphene citrate is, it is one of the very important ovulation induction. So to induce ovulation we are using the dose. So what is the normal dose in females we use? 50 mg. 50 mg per day. So here we can give either 25 mg daily or 50 mg on alternate days. Okay, for a male infertility. That is clomiphene citrate. And if the defect is at central level, we can give gonadotrophins. Okay, same gonadotrophins whatever you are giving in the females. We will discuss what are all the gonadotrophins we give. So in a case of retrograde ejaculation, we should give ephedrine and phenylephrine. So how the question was asked for you? Which of the following is not used in male infertility? A. Clomiphene, B. Ephedrine, C. Phenylephrine, D. Digoxin. Digoxin. Okay, is it clear? So this is how they ask question for you. Same, it blocks the whatever the clomiphene it is going to act, it is going to something like in females it is anti-estrogenic. In males also same function. So once this decreased, normally what did we discuss now? Decreased testosterone, what it is going to do? Increase FSH. Increased FSH, once again it is going to stimulate. So it is one anti-hormonal substance which is used, but still which is used for induction. Okay, even though it is anti-hormonal, but we are using it for a good purpose. It is so simple, either the clomiphene citrate either in males or females. So from FSH, this is estradiol. So it is going to block this estradiol receptors at the pituitary level. Okay, it is going to block estrogen. What does this body thinks? That is, there is defective estrogen. Now it starts secreting more FSH. This FSH in turn increases spermatogenesis in a case of male, whereas in a case of female it is going to cause oogenesis. Okay, this is how it will work. Those are drugs which are used for retrograde ejaculation. Okay, not for induction or ovulation, induction of spermatogenesis, just to prevent retrograde ejaculation. So we have done everything, but still the patient has not yet improved. So what are all the indications for artificial insemination? This is the question they have asked you. So they don't give you. So a patient comes with abnormal semen analysis. When do you want to give clomiphene? When do you want to go for artificial insemination? And there are two types of artificial insemination. One from the husband. Second thing, you cannot give the husband. When do you want to take a donor semen? So you will take a sample from the, not from the husband, but some unknown donor where the patient doesn't know who is the donor. So we will take a donor semen and we are going to inject into the female. Okay, these are all the various things. Yeah, or else we can go for intracytoplasmic sperm injection. If the count is very less, severe oligospermia, in such a cases what we will do? Even though if we do intrauterine insemination, for intrauterine insemination there should be minimum sperms. Even the minimum sperms are not seen. So what we will do? We will take a sperm and directly we will inject the sperm into the egg. Okay, into the egg cytoplasm. That is called as intracytoplasmic sperm injection. So what all we will see in the various things. In the later slides, at the last I will tell you what is the treatment and all. Okay. Now we have done male factor. Is it clear? Workshop of male factor. How to investigate a male factor infertility. Okay. So this is the intrauterine catheter. Nothing but whatever the semen. They will process the semen sample. Okay. They will process it and they are going to remove the abnormal sperms and all. So they will give a very good amount of fresh sample which contains good sperms. Only which are very viable sperms, and they will culture it in a tissue culture and they will give the semen. Whatever the processed sample through this is called as insemination catheter. So we will insert the catheter and directly we will insert the sperms into the uterus. Okay, this is called as intrauterine insemination. So either, that's what I told you, either it can be from the husband or from the donor. Okay, there are two types. So what are all the indications for this artificial insemination? Just now I told you. So if the count is very less, oligospermia, severe oligospermia, we are going to go for artificial insemination. So even if you give clomiphene, it won't. Even if you give clomiphene, it is not going to work. Okay. In such a severe condition, there is. If you still want to wait and give clomiphene, meantime the patient will land in aspermia. Okay, or severe agiospermia. What is agiospermia? Decrease? No, not decreased. Eju is no sperms, absent sperms. Oligo is decreased. So when the patient is in oligo, go for intrauterine insemination, severe oligospermia. Okay. Or else if you keep on giving clomiphene citrate, meantime the patient will land in agiospermia. So severe oligospermia is an indication for insemination of the husband. Remember, okay, husband. Or if the patient is not able to deposit the sperm in the female, what are all the conditions? Hypospadias, premature ejaculation, impotency. So now the male is not able to put the sperm into the female. So what we'll do, we'll collect the sample from the male, we are going to put the sample into the female. Okay. So these are all the causes. So impotency, premature ejaculation, retroejaculation, hypospadias. Okay. And one more thing, why do we are taking this anti-sperm antibodies? It is indicating there is cervical. So even though the sperm, if we put it, but the cervix is blocking it. So now I want to transmit directly into the uterus, crossing the cervix. Okay, what do? I will go for artificial insemination. So know the concept why we are doing it, so that the answering for you is very easy, so that you will not, there is no need to mug up. Is it clear why every reason is in cause for insemination? No, even we have tried in many things, but still we don't know what is the cause. Everything is normal, but the patient is not able to conceive. It is called as unexplained infertility. The incidence is 10%. So in such a conditions, go for this artificial insemination from the husband. Now we will see when we need to take a donor. So husband is not working. Why husband semen is not working? In which conditions? Agiospermia. There is no sperm at all in husband semen. So now the female, whatever you put, it is only prostatic secretions. So definitely what you need to do? You need to take a sperm from the donor and go for female insemination. Or any immunological factors which are not correctable. So whatever the immunological defect is in the husband, if you are going to take the sperm from that husband, the baby is going to get carried. So any immunological defect which is uncorrectable, I am not going to take the sample from the husband. Next, genetic diseases. Okay. And severe oligospermia and asthenozoospermia. What is asthenozoospermia? Defective motility. Even though if you put it in the uterus, but it has to travel through the tube, and then only the fertilization should occur in the ampulla. If it is not traveling, what is the use? There is no use. So in such a conditions, I have to take a donor. Okay. These are all the various indications for a donor. These have been asked for you in the previous exams. Yeah, Shan, it is correct. Yeah, answer this. So there is absence. Absence is, but there is fructose. What does it indicate? It is aspermia or agiospermia? Why not aspermia? Fructose is seen. So then what is the cause? A, B, C, D. How many of you for A? Lift up your hands. Something you should answer. A, B, C, D. How many of you for A? B? B, 3 hands. C? ఇట్లా అనుకుంటే కాదు, ఇట్లా ఎత్తాలా. రుద్దుకుంటున్నారో లేకపోతే చేతులు ఎత్తున్నారు నాకేం తెలుస్తుంది, ఎత్తాలి సరిగా ఎత్తండి. ఫర్ B or C? C how many? C only 3, 4, 5, 6. Good, very good. 6. Yeah, whoever answered C, it is correct. Now tell me why C. Fructose, from where it is secreted? Yes, exactly, the secretion. So from where the fructose is secreted? From secretions. So it is showing absence of spermatozoa. Where the mumps, just now I told you, where it is going to affect mumps? Orchitis, testis. Prostatic infection also, it is testis. So there can be absence of the spermatozoa, but not the fructose secretion. Seminal vesicles and all, it is secreted. Okay. So there is block in the efferent duct. That's why we are able to see the only fructose, but not spermatozoa. So defect is at the testicular level. क्या doubt है? Okay, B, can you see sperms? Prostatic infection. What is? Yes ante enti? Em chustarani? No, even prostatic infection, it indicates it is associated sometimes with orchitis. Even they are going to damage the spermatozoa. Okay, it is not simple prostatic infection. Okay, orchitis or prostatic infection, they are going to damage the spermatozoa. If you are seeing fructose but not spermatozoa, there is block somewhere. The testis is producing. But other than that, okay, the answer is C. Coming to female factors, we'll take a break. Even I am tired. Okay, we'll take a break. Fructose, where it is secreted? Prostata seminal vesicles. Appadi nunchi chustuna evaru cheppatledu. Prostate na? Huh? Prostata seminal vesicles. Where is the fructose secreted? Prostate kadanna. Tomorrow's question for you. Did you search? Where do we do double setup? So tomorrow's question for you. Where is the site of secretion of fructose? Okay, tomorrow come with an answer.